Keep your mic muted. Keep your mic muted. Yeah. So this has 3 parts. I'll first introduce chief guest. Then a small felicitation by our chief guest about our club and our people. Then the keynote address, and next follows the interaction. I will introduce the chief guest. Salvi sir is an excellent person, number 1, top leading promoters in India. He is most known worldwide. He is the founder and director of Chest Research Foundation in Pune. He is a member board of directors of Gold Society, Global Initiative for the COPD. Is a vice president of Indian Chess Society, international advisory board member on the Lancet Medicine. Is a chair, chronic respiratory diseases section, global burden of disease in India from 2015 onwards. Is a member of the steering committee of air pollution, Minister of Health and Family Welfare government. With more than 200 published papers in peer-reviewed international journals. Is a top 1% of all respiratory science in the world. And of late, a report has come that all these journals have been quoted most widely by many pulmonologists throughout the world. He is top in it. So I am very proud to have you with us, sir. And you won't believe when I told him, sir, he immediately agreed. I didn't talk to him, immediately agreed. He was impressed by our club and immediately agreed. And then he told me, this also you won't believe. He told me, Dr. Sekar, you should give me the topic right now so that I can start preparing right from now on. That was 30 days ago. This amount of humility and how humble great people are. I was really moved by that comment of him. So it's very great to have you with us, sir. We have Dr. Kumar sir and our chairman M.D. Chandrasekharan as our chairpersons for this. The topic which we have given to Salvi sir is changing paradigms in the pathophysiology and the management of bronchial asthma in India. You know, asthma has taken a sea change over the past 2 decades, and many people are still treating asthma in the good old way. A lot of things have changed, and who better person can I get to talk about this than our Salvi sir? So I welcome Dr. Kumar sir to introduce the topic. He is the chief consultant in the Department of Pulmonology and sleep medicine. He has come to our club so many times. He is a very passionate teacher. He is a MBBS from Trinidad College, MD Stanley. He is a gold medalist in pharmacology and pediatrics in UG. He is a university topper and deserves of 3 gold medals. He is a principal investigator at the COPD Global Study. And again, I would like to say he is so humble. When I accosted him a chair, he asked me, sir, am I fit to chair a session by Salvi? Can I do it? That's what Kumar asked me. I was bold by his humility also. And next chair is our MGC sir. He is our own first pulmonologist of Dindigul. He is senior citizen retired and officer of the district TB center and chairman of the club for Dindigul right from 2015. Now I hand over the mic to Kumar sir. I will stop screen sharing and Salvi sir can take over.
Good morning. Yes. Good morning, sir. Good morning, every one of you. First of all, I would like to thank dignitaries of Club Pulmonale, J.C.Sekar sir, Muralidharan sir, and every one of the club for inviting me to. It's like a home club, one of the favorite club for me, for inviting me in this wonderful academic session. And I am very happy and very pleased, humbled, and proud to introduce Dr. Salvi sir. I know him for so many years. He's one of the topmost, wonderful, humble, one of the eminent orator I have ever seen. And I have seen your talk a lot, sir, and I have grown and you have been one of my inspiration. Thank you, Sekar sir and other Murali sir for inviting me to at least have an interaction with Salvi sir. And he'll be talking about changing paradigm in the management pathophysiology of bronchial asthma. As we all know, in the previous decades, the focus was only on bronchospasm. As the years goes on in the 1990s, 2000, there have been a development of immunological theory, particularly eosinophilic inflammation, which have been the main orchestrating and initiating factor for the pathogenesis of bronchial asthma. So there have been a lot of studies going on regarding Th2 inflammation and cascade of inflammatory mediators like 4, 13 and TNF alpha, everything. And because of that, the pathogenesis have been more towards the immunological mechanism as well as the phenotypic and endotypic variation, eosinophilic, non-eosinophilic, granulocytic, all so many things. The focus is mainly on an underlying persistent inflammation which is happening regularly, thereby propagating the seriousness of bronchial asthma. And even Gina has introduced the role of biologics in the stage 5 guidelines of severe asthma who have been refractory to other conventional regimens. So many drugs have been there, anti-IgE and anti-interleukin 5, Mepoli, interleukin 5 receptor antagonist, Benroli, Dupilumab, so many things, and even surgical option of bronchial thermoplasma. So innovativeness and update studies are going on and number of drugs are in pipeline for upgrading the management and making sure that everyone is in control. I would rather say, rather than a cure, a control of asthma and severe asthma, and thereby they are having a good quality of life. That's what is important. Healthy quality of life and making sure that they are free of exacerbations. So I don't want to talk much and waste Salvi. And over to you, sir.
Thank you very much, Dr. Gopal, for those very, very kind words. At the outset, I would like to express my very, very sincere thanks to Dr. Sekar and his team of such dedicated people from Club Pulmonale in Dindigul for, first of all, inviting me to this wonderful 7th Annual Congress, and for giving me this opportunity to share with you some of the knowledge that I have earned or gained over the last so many years through research and through the work that we have been doing in the field of asthma. I am particularly proud of this club because they have very sincerely and with a lot of dedication have conducted these CME programs on a regular basis. It is not very common to see such wonderful dedication. 85 CME programs so far since the year 2014 on the very same day in January so many years ago. And to host the conference regularly by having such a wonderful scientific program and having such wonderful faculties is a wonderful achievement by this small club in Dindigul. I believe that this could be one of the role model clubs that people across India should have. The amount of dedication and commitment that they have, the leadership that they have right at the front is really, really amazing. So congratulations for your 85 CME programs and for the 7th Annual Conference. And I hope that this will continue for many, 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 many years to come. I would like to bring you greetings from my current institute called Pulmonale Research and Education Foundation, also situated in the city of Pune. I was earlier the founder director of the Chest Research Foundation, and the 17 years that I spent there, we did a lot of research in the field of asthma and COPD. And I'm going to share with you some very important and interesting novel findings that we have very recently got, because that is such an important piece of research that should change practice in our country. India is currently the #1 country in the world when it comes to the number of asthma cases. Look at this graph over here. Let me put this into a pointer form. Yes. So if you can see my laser pointer, this is the year 1990 onwards till 2019. So this is the latest piece of information that is available from the Global Burden of Disease report. And this is data that has been analyzed until the year 2019, not yet published. So this is something which is very, very new. You can see that this line represents India when it comes to asthma cases from 1990 onwards. And something happened in the year 2004, something happened in the year 2011, when the number of cases of asthma have suddenly increased. And we have now overtaken the United States of America as the country that has the most number of asthma cases. 34.3 million cases of asthma in India, out of the 262 million that are estimated to be present in the whole world. So out of every 100 asthmatics in the world, 13 are from India. And as I said, this is the latest information that is currently available. More important than that is this very slide. And I feel very sad and ashamed to share this data with you. India contributes to 43% of all global asthma deaths. Although we contribute to only 13% of the burden of asthma, when it comes to asthma deaths, out of 100 asthma deaths that occur in the world, 43 occur in India. And this is, I believe, a very important and I believe a very sad slide that tells us the current state of the art of management of asthma in our country. Look at where the other countries are, Indonesia, China, they're far, far, far below. Just to give you a feel of that, I just made the number of the ratio between the asthma deaths to the asthma cases. So we have 570 per 1,000. And look at the other countries. In most of the developed countries, the number of deaths is around 10 to 20 cases per 1,000 asthma cases, 10 to 20. But in India, it is 570. The highest number of asthma deaths in the world occur in India. And I think it's important for me to share this information with you. When it comes to disability-adjusted life years, and this is a health metric that many policymakers like to use. This is a combination of suffering and death. Disability-adjusted life years, a combination of life years that are lost and life that you live with suffering. So combining suffering and death, this is the most important health metric that many policymakers use. Now, when it comes to asthma DALYs, you can see that India is right at the top. Highest number of asthma DALYs in India. In fact, India contributes to 27% of all global asthma DALYs. If you look at China, that is number 2. It's 5-fold lesser than India. And that's the difference between the first and the second country in terms of asthma, suffering, and death. This is an extremely important piece of information that our country needs to be aware of. I was, in a way, fortunate enough to be the national leader for the Asthma Insights and Management Study, a global study that was conducted by 3M. And this study that looked at the various aspects of asthma management in many countries across the world. So it included United States, EU CAN stands for Europe and Canada, LA stands for Latin America, and AP stands for Asia Pacific. And within Asia Pacific, IN represents India. So this is about 20 countries that took part in this global study that looked at various aspects of asthma management. This was published in the journal JAPI in 2015. Now, when you look at patients reporting daytime symptoms, you can see that India is among the top 3 countries in the world where asthma patients have the highest prevalence of daytime symptoms. When it comes to nighttime symptoms, you can see that India is right at the top. 32% of the asthmatics that were investigated complained of nighttime symptoms. 1/3 of our asthmatic patients complaining of nighttime symptoms. And the third parameter that we looked for was patients who have well-controlled asthma using the asthma control test. Not that other countries are doing well. Most of the countries are less than 30%. So asthma control occurs in less than 30% of their population in all the countries. But look at where India is. 0%. 0%. I think it is something that we need to really worry about. Because, if none of the asthmatic patients in India have well-controlled asthma, it is something that we need to worry about. The study was conducted in 8 cities and towns in different parts of India and included around 400 asthmatics in each of these countries. So none of these 400 asthmatics who were included in this randomly selected population had well-controlled asthma. Now that is a current scenario of asthma management in India. We also looked at various other questions. My asthma makes me feel like I don't have control of my life. These are all the Asia Pacific countries in different colors. Green is India. And you can see that about 80% of the asthmatics in India said that my asthma makes me feel like I don't have control of my life. When we asked them, I feel inadequate in relation to my peers because of my asthma, India is again the topmost country. 64% of the asthmatics complained that. My asthma affects how I feel about myself. Right again, India is right at the top. So something is seriously going wrong in the way asthmatics are managed in our country. What I have shown you is the current data suggests that there is a lot of suffering that these asthmatic patients undergo, and the deaths due to asthma are particularly very high. 43% of all global asthma deaths occur in India, and this is something that, as I said, is very, very worrying. Why is that happening and what should we do is what I'll be covering in this part of the presentation. But before that, let me take you a little through the history of how our understanding of asthma changed with time. Now, this is the year 3000 BC until 400 BC. So this is about 5,000 years ago during the Egyptian period. The word asthma was not yet coined then. The word asthma was coined by Hippocrates after this period. But in the literature, there is some suggestion that there's a respiratory disease that is associated with noisy breathing, which perhaps indicates the presence of asthma during that point of time. Because we know that wheezing or noisy breathing is a very common clinical manifestation of asthma. At that point of time, it was believed that asthma or that noisy breathing lung disease was caused by demons, spirits, foreign gods, and unhappy gods. Because at that point of time, there was absolutely no understanding or insight about the human body. We did not even know what are the organs that are made up in the human body. So at that point of time, it was believed that this was the cause of asthma. And therefore, the treatment for asthma was obviously related to the belief that was associated with that. So you offered sacrifices to God, you burnt incense, or you drank the owl's blood to satisfy the spirits. These were the treatments for asthma at that point of time. Not only that, but even eating the excreta of camels, of horses, and of crocodiles was believed to be a very important part of asthma treatment. So how the belief and the understanding of the asthma pathophysiology led to the treatment is a very simple point. I just wanted to highlight this current, the Bathini fish prasadam that is still happening in Hyderabad, where on a particular day there are lakhs and lakhs of asthmatic people who go to Hyderabad with the belief that they're going to get cured by this fish that has been fed with this so-called secret medicine, and this live fish is then put into your throat, and you have to swallow it. You are actually told that as the fish goes inside, it eats up all the mucus that is present in the airways, and therefore your asthma is completely cured. Well, I mean, I can't understand a fish going through the esophagus into the stomach. How can it eat up the mucus that is present in the airways? So I think there are lots of issues with regard to this. And Dr. Ajit Vig made a comment in this article that was published in the British Medical Journal a few years ago, saying that there is absolutely no evidence that this works. Dr. Ajit Vig is a very senior person and a senior pulmonologist in Hyderabad. And he said that on the contrary, we have seen about 10 to 15% of patients whose condition worsened after they went to take the Hyderabad fish. And then he goes on to say that in my practice of 20 to 25 years, I have not seen a single patient whose condition has either improved or who has got completely cured with fish medicine. My mother suffered with asthma, and during my school days, when I did not even join medical college, I remember my mother going with my relative to Hyderabad in an acute episode of asthma exacerbation with the belief that she would get cured by the Hyderabad fish. When she returned, she came with an acute exacerbation of asthma and she needed to be hospitalized. And at that point of time, she was treated with IV aminophylline and high doses of systemic steroids. So clearly, I think we still live in that 5,000-year-old of belief about some of these treatments about asthma. Then in 470 to 370 before Christ, this was the period of the Greek culture when Hippocrates, the father of modern medicine, was born at that point of time. And during his period, he coined one term called asthma that actually meant moderate labored breathing. So depending on the severity of the breathlessness, mild breathlessness was called dyspnea, moderate breathlessness was called asthma, and severe breathlessness was called orthopnea. So asthma was described by Hippocrates so about 2,300, 400 years ago, primarily as a description of the severity of breathlessness. And this is what he believed was the cause of asthma. He said there is something wrong that is happening in the brain. There is some evil humor that is being generated in the brain. This evil humor then comes to the cribriform plate of ethmoid into the nose, and this will manifest with nasal symptoms of nasal blockage and rhinorrhea and all that. And this then flows down into the lungs or into the chest, and that manifests with symptoms of shortness of breath and cough that is so very characteristic of asthma. So this is what he believed was the cause of asthma. It was triggered off by cold weather and moisture, and that is what produced this so-called evil humor. And therefore, the treatment that Hippocrates recommended at that point of time was you need to get rid of this evil humor that is circulating in the body by making incisions and letting the blood drain itself out. So removing blood or bloodletting by making incisions on the skin was an important treatment for asthma that Hippocrates recommended at that point of time. Then as we go down the history, we know that before the year 1700 AD in Tamil Nadu, and there's a big history that is written about this, where the leaves of datura were actually used to relieve the symptoms of cough and breathlessness. So you take the dried leaves of this datura plant, you grind it, then you burn it, and the smoke that comes out of it, you inhale that, and that would significantly relieve your symptoms of cough with mucus production and breathlessness. And this is a very, very popular treatment that was recommended in Tamil Nadu, that started in Tamil Nadu, that was used all over India at that point of time. Around that point of time, the Buddhists used to smoke a lot of the dried leaves of datura as a psychoactive substance for tantric, religious courses. So it has been known that dried leaves of datura have been useful. Now, when the British came to India, the East India Company, Dr. James Anderson, who was earlier a botanist, was made the chief physician general in India. And during his travel to Tamil Nadu, in Madras at that point of time, he saw people use this as an important treatment to relieve their chest complaints. So he gathered all this and took it back with him to England. And there he realized that they are genuinely useful. And that is the time when he actually made powdered leaves of this and put it into what were called as asthma cigarettes. So if you had to relieve your asthma, what you actually needed to smoke was asthma cigarettes. Isn't that an irony that, the treatment for asthma at that point of time was asthma cigarettes? And then not very far away from that, they actually isolated the physical or the pharmaceutical product that was causing this effect. The anticholinergic ipratropium was actually invented because of the extract that they got from the datura leaves. So this is how asthma was being treated in India and in the year 1700. We do not know how many years before that. Perhaps maybe for 2000 years, people have been using this in India to relieve their shortness of breath. Then between 1900 to 1980, that was a time when a lot of autopsies were done. Perhaps one of the first autopsies were done during this period. And asthmatic patients who died, when their lungs were removed and they were seen under the microscope, there were very specific features that were noted at that point of time. Mucus gland hypertrophy and hypersecretion, presence of mast cells and eosinophils, release of histamine and other mediators, and smooth muscle hypertrophy was all that was seen in the biopsy of the bronchial tissue in asthma patients who died. During this time, there was a lot of physiological advancements that also took place. The spirometer was invented in 1945. Actually, it was invented in 1845, but it took 100 years for that to be used in clinical practice. So 1945 was when the spirometer was developed, the Hutchison spirometer. Then we had the peak flow meter and various other physiological tools that suggested that in patients of asthma, there is airway smooth muscle obstruction. There is contraction of the smooth muscles, narrowing of the airways that gives rise to the symptoms that are present in these patients. And based on that belief, the treatment was to give bronchodilators, so drugs that cause relaxation of the smooth muscles in the airways, or to give antihistamines or mast cell stabilizers. So these were the treatments that were recommended between the period of 1900 to 1980. So beta agonists, which were the drugs that relax the smooth muscle cells, became being used left, right, and center. Adrenaline, isoprenaline in high doses, and very specific beta-2 agonists like salbutamol, phenoterol. All these drugs started being used in plentiful in the management of asthma soon during that period of around 1980. But some very important observations were made up to the year 1990. As you can see here, when adrenaline was given to patients of asthma, the number of deaths increased in England and Wales as well as in New Zealand. So the treatment that was given for the relief of asthma actually caused more deaths. Then isoprenaline was introduced, which is a selective beta-2 agonist. The number of deaths also increased in England and Wales. Then high-dose isoprenaline was used. Again, the number of deaths increased both in England and Wales as well as in New Zealand. And then finally, phenoterol, which is a drug that is very similar to salbutamol. It was prescribed on a regular basis for the treatment of asthma. And suddenly, the number of deaths increased in New Zealand. There was no phenoterol in England and Wales, and therefore there was no deaths over there. But in New Zealand, when phenoterol started becoming used, then the number of deaths suddenly increased. And you can see here that as the availability of phenoterol became less and less, because it started becoming banned, because it was causing asthma deaths, the asthma deaths, which is in the line, started going down. So what did we learn from this? That regular use of beta-2 agonists in the treatment of asthma causes asthma deaths. And it was after these two papers were published that salbutamol started becoming recommended to be used on an SOS basis. None of us should ever prescribe salbutamol on a regular basis. It should only be given as and when required, not on a regular basis. Why do we not prescribe salbutamol on a regular basis? Because it causes asthma deaths, and the evidence for that is very strong. So we know that beta agonists, they cause bronchodilation and therefore release symptoms. They are excellent at doing that. You take that salbutamol inhaler and within 5 minutes, you feel relieved. That's how efficient they are in causing bronchodilation. But there is a downside also to the beta agonists. They are not safe drugs. They increase smooth muscle hyperplasia, they increase smooth muscle hypertrophy, and therefore totally they increase bronchial hyperresponsiveness. a very, very important component of asthma. They increase bronchial hyperresponsiveness and they also mask the underlying inflammation. Now, these disadvantages of beta agonists are quite significant and therefore they have to be used very carefully. How many of you all prescribe this? A salbutamol or levosalbutamol inhaler, 2 puffs twice a day, or salbutamol or levosalbutamol inhaler as and when required, or tablet salbutamol 2 milligrams or 4 milligrams thrice a day without giving any other medication. How many of you all treat your asthma patients in this manner?
It was long back, sir. Nowadays we don't do.
If you are, then you're actually causing more harm to these patients. And that's the message that I wanted to convey. In 1985, the fiber optic bronchoscope was invented. And that gave an opportunity to put the scope into asthma patients who are alive. And for the first time, you were able to take tiny bits of tissue from the bronchial mucosa in patients who had asthma. This is Ratko Djukanovic at the University of Southampton, where I had the honor and the privilege of doing my PhD. And he's the first person at that point of time to actually conduct these biopsy studies in asthma patients. And these are the nurses who are good friends of mine. You can see this asthma patient undergoing a bronchoscopic procedure. Now, at the same time, the molecular biology tools such as immunohistochemistry and the reverse transcription PCR tests also became very popular. And because of that, we started getting a very important insight into what happens in the asthmatic airways. And this was a very important conclusion that came from the research that was published in 1990. Asthma is an inflammatory disorder of the airways. There is a fundamental defect that occurs in the asthmatic airways. Corticosteroids are the only drugs that reduce mucosal inflammation. There is no other drug that can reduce the inflammation as much as what inhaled corticosteroids do. Inhaled corticosteroids are better than oral corticosteroids, obviously because of the safety profile. Inhaled corticosteroids, with or without long-acting beta agonists, they became asthma management after 1990. Antihistamines were shown to have no effect at all because until that point of time, a lot of asthmatics were indeed treated with antihistamines. Antileukotrienes came much later than 1990, and we know that they are useful in a certain set of asthmatics, but by and large, they're not effective in all cases of asthma. And when you compare them to inhaled corticosteroids, they still have a much inferior role. So this is a very important insight that came into the understanding of asthma in 1990 onwards. And I must tell you that MD dissertation topic in 1991, I chose the role of inhaled corticosteroids in the management of asthma because I read a book written by Professor Peter Barnes in 1990, which I had read at the British Council Library, that there is something called inhaled corticosteroids that are very effective in the treatment of asthma. So I approached Cipla in 1991 and I asked them to give me samples of salbutamol inhaler and the beclomethasone inhaler. And I did a comparative study between salbutamol and beclomethasone in 1991. Perhaps the first dissertation or the first research on inhaled corticosteroids in our country. 50 patients received only salbutamol and 50 patients received only beclomethasone. And as expected, those patients who received the inhaled corticosteroid had improved symptoms, improved quality of life, better peak flow values, reduced exacerbations, and reduced hospitalization. So I was very convinced at that point of time that this is a wonderful drug for the treatment of asthma. And that's what I started treating my mother with. And her asthma got completely changed when I put her on inhaled corticosteroids. So this is the basic fundamental defect that occurs in patients with asthma. I'm sorry I cannot play the video over here, but I'm sure you can recognize what is the name of this plant. It is called Touch Me Not or Mimosa pudica or Chui Mui in Hindi. The moment you touch it, all the leaves start closing. Everything just starts closing. This is exactly what happens to the smooth muscles in patients with bronchial asthma. Cold air, dry air, environmental irritants, allergens, or change in the electrical charge that occurs in cloudy weather, all of them, they trigger the smooth muscles in the airways to cause constriction, just like what happens to this touch me not plant. The smooth muscles also constrict excessively to chemicals such as histamine, methacholine, mannitol, or even beta blockers. And this whole concept is called as bronchial hyperresponsiveness, and it is the hallmark feature of asthma. Healthy people do not respond to any of these substances like cold air, dry air, dust, environmental irritants, allergens. Healthy people can tolerate all that. But asthmatic people cannot tolerate any of this because of bronchial hyperresponsiveness. There is a genetic basis for asthma. If the gene is very strong, it can grow in any environment. I just wanted to show you that image over here. There are 100 genes that are associated with asthma. We still do not know which is the most important gene, but there are at least 100 genes that have been shown to be associated. Why am I sharing with you this important piece of information? A family history is a very, very important thing that you should ask when you are interrogating your patient of asthma. If there is a presence of family history, the risk of that person having asthma increases by around 7 times. 7 to 8 times is the risk if you have a family history. Asthma is one of the most heritable diseases that you can encounter. You know, there are 3 important diseases that are very, very strongly genetic. Asthma, schizophrenia, and leukoderma. Very strong genetic. Asthma is perhaps one of the strongest genetic diseases. So whenever you take a history, always ask for a family history of asthma or a family history of atopy. Atopy includes asthma, allergic rhinitis, allergic conjunctivitis, atopic eczema, or migraine. Anybody in your family, blood relatives, if they had any of these atopic disorders, then it is likely that this respiratory symptom that you have now is likely to be asthma. And then there are environmental factors that are equally important for causing asthma. You have the allergens, you have the air pollutants, and so on. One mosquito coil produces as much amount of smoke that is equivalent to 100 cigarettes. One dhoop agarbatti produces smoke equivalent to 500 cigarettes. Then you have the burning of incense. Then you have the damp walls or the fungus that is inside your house. Then motor vehicular exhaust, especially diesel, the black smoke that comes out of it, industrial exhaust, and then your deodorants and perfumes that you have in your house. These are all environmental triggering factors for asthma. It's important to know that. And I must particularly emphasize on these 3 because these are very, very commonly used in Indian homes. And many people are not aware that they are responsible for triggering of asthma or even causing asthma. Is regular consumption of fast foods associated with asthma? The answer is yes, significantly increased risk. So if you like to eat this kind of food, you're more likely to develop asthma. Is there anything other than the opposite to that? Yes, if you consume fruits on a regular basis, then the risk of you catching asthma can be significantly reduced. Obesity is now becoming a very, very important risk factor for asthma. Very, very important. And obesity is occurring not because of the food that you eat or because of the lack of exercise. Obesity is occurring because of exposure to air pollution. Air pollution causes obesity, and obesity increases the risk of developing asthma. There is now a lot of literature that has come in the last 5 years that have shown for the first time that air pollution causes obesity, and that increases the risk of asthma by 60% to 300%. This is a very important slide that I would like you to pay particularly a close attention to. Here is a normal airway. This is the mucosa, and this is the lumen through which air goes in and out. Normal, healthy individual. This is what happens when that person develops asthma. Because of smooth muscle constriction, because of mucosal edema, there is swelling of the mucosa. The lumen size becomes very small. The passage of air entry becomes very narrow, and therefore you get the symptoms of cough, breathlessness, and wheeze. Now, if you treat this patient with bronchodilators only, the smooth muscles relax, the lumen becomes bigger in size, and the patient feels symptomatically better. And therefore he says, this is the best treatment for my asthma. I feel better. My airways have opened. But after the effect of the bronchodilator goes, the patient goes back into this phase. So by treating your patient only with bronchodilators, you're making your patient switch from this phase to this phase on a regular basis. Now tell me what happens if I go to the gym, I take a piece of weight and I do this contraction, relaxation, contraction, relaxation, contraction, relaxation. What happens to my muscle? My muscle becomes big in size. Not only the skeletal muscles, but even the smooth muscles become big in size when you do contraction and relaxation. So when you're treating your asthma patient with only bronchodilators, the smooth muscles contract, relax, and because of that, the smooth muscles hypertrophy and hyperplasia. There, the bronchial hyperresponsiveness increases a lot. So by treating your patient with only bronchodilators, you're making the asthmatic patient airways worse. The only way that you can convert your patient to come back to normal is by giving inhaled corticosteroids. These inhaled corticosteroids are to be given on a regular basis, and because of the risk of causing increasing smooth muscle hypertrophy and hyperplasia, beta agonists should be given only as and when required. Have you understood the importance of this? Because if you are treating your asthma patients with regular bronchodilators, you're actually causing harm to that patient, unless you're combining that with an inhaled corticosteroid. So combination of a bronchodilator with an inhaled corticosteroid is allowed to reduce the harmful effects of the bronchodilators. A very important study published in 2000 in the New England Journal of Medicine. Here is a number of canisters of inhaled corticosteroids used per year. So 2 puffs in the morning, 2 puffs in the evening is a fairly regular dose of inhaled corticosteroids. 1 canister lasts for 1 month. And if you take that on a regular basis, you should be using 12 canisters of inhaled corticosteroids in a year. Now, here is a very important study from Canada that looked at the association between the number of canisters that the asthma patients use and the deaths that were associated with it. What can you see over here? As the use of inhaled corticosteroid increased, asthma deaths decreased in a beautiful manner. If you took less than 4 canisters of inhaled corticosteroids per year, you had a greater chance of dying. If you use at least 6 canisters of inhaled corticosteroids a year, your risk of dying reduced by 50%. So at least 6 to 7 canisters of inhaled corticosteroids a year can reduce asthma mortality by 50%. And I thought this is a very important piece of information. I wanted to find out what is the use of inhaled corticosteroids in India by our asthmatic patients. 34.3 million asthmatics. How much inhaled corticosteroid do they use? So I had access to this report from the Global Burden of Disease because I chair the chronic respiratory disease section. So I had access to the asthma burden in India, the asthma deaths, asthma dialysis, and I had also information of state-wise and the union territory-wise information about asthma burden. And in addition to that, I managed to get the data of inhaled corticosteroid sales, every single inhaler that is sold in India from all companies, all put together, whether it is a pressurized meter dose inhaler or whether it is a dry powder inhaler, all the sales are collected by this organization called IQVIA or IMA. I collected this information from them and I started doing some very basic fundamental analysis. 4.3 million asthmatics in India. In an ideal state, each asthmatic must use 12 units of ICS, correct? One canister per month and therefore 12 units of ICS per year. That is ideal. So what should be the total ideal sales of ICS in India? 34.3 million into 12, which is 412 million units of ICS should be ideally sold in India. When I got the report from the IQVIA, the actual sales of inhaled corticosteroid drugs is only 39.6 million units, which is 9.6%. Now, a lot of these inhaled corticosteroids are also used by patients of COPD. Let's assume that 1/3 of this is used by COPD patients. Then the use of ICS by asthma patients in India is only 5 to 8%. Now, this is a shocking figure for me because it tells me a very important message there is a serious underuse of inhaled corticosteroids in our country. Less than 10%, I would say between 5 to 8%. Then I did something very interesting. This is the sales of ICS in different states in India, and this is the asthma death rates. Each dot over here is a state of India. So maybe this is Maharashtra, this is Punjab, this is Haryana, this is Kerala, Tamil Nadu would be somewhere over here. You can see a very nice inverse correlation. As the sales of inhaled corticosteroids in the state increased, the asthma deaths decreased. And the ratio was minus 0.56, very, very significant. So deaths in India are associated with less use of inhaled corticosteroids. Now, when we looked at disability adjusted life years, so dialysis that I said, very nice negative correlation. As the sales of inhaled corticosteroids in the states increases, the suffering and deaths associated with asthma decreases. Now, this is telling me a very, very important message that India is contributing to 43% of all global asthma deaths. Is it because we are not using inhaled corticosteroids in the management of asthma in our country? The evidence is here. Less than 10% of our asthmatics are actually getting inhaled corticosteroids. Then I did state-wise a graph over here. Depending on the number of asthmatics, how many units of inhaled corticosteroids should be sold compared to actually how many units are sold. So this is Uttar Pradesh. 49 million units should be sold, but only 4 million units are sold in real life. You can see Tamil Nadu over here. 18 million units of ICS should have been sold in the state of Tamil Nadu, depending on the asthmatics, but only 3.3 million units are sold in Tamil Nadu. So look at the underutilization of inhaled corticosteroids in our country. So what is the carry home message that I would like you to take from this presentation? All patients of asthma must be prescribed an inhaled corticosteroid, either with or without a short-acting beta agonist or a LABA. Aerocort is not a bad drug. Foracort is not a bad drug. And here is something that I would like to make a plea to all the delegates listening to this presentation. All doctors attending this conference should take a pledge that they will treat all their asthma patients with inhaled corticosteroid. No asthma patient will be denied an inhaled corticosteroid is something that you should take from this presentation. If you look at the GINA 2015 guidelines, mild intermittent asthma was recommended to be treated only with as and when required short-acting beta agonist. So as needed short-acting beta agonist in mild intermittent asthma. It was suggested that you may consider low dose of ICS, but by and large people only started using SABA as a treatment for mild intermittent or even perhaps for mild persistent asthma. Then this very important study was published in 2020 by Dr. Richard Beasley. Three groups, patients of mild asthma receiving only salbutamol or budesonide twice a day with SOS salbutamol or budesonide plus formoterol as and when required. 52 weeks of treatment. And what they found was something very interesting. So the three colors over here represent the three arms over here. So only salbutamol, budesonide twice a day with SOS salbutamol, and budesonide formoterol as and when required. You can see that the number of exacerbations reduced in the third group consistently. If you look at the annualized exacerbation rate, both the second and the third groups seem to have done well. But when it came to the number of severe exacerbations, then a very important observation over here. Patients with mild asthma need to be treated with inhaled corticosteroids. And therefore the guidelines in 2020, the GINA guidelines were changed, where a very important change that occurred after 30 years, that even patients with mild intermittent or mild persistent asthma must be treated with inhaled corticosteroids. So what is the carry home message? Patients with all severities of asthma must be given inhaled corticosteroids. So here are the carry home messages from my presentation. India contributes to 43% of all global asthma deaths. As responsible doctors, we need to change this on a war footing level. Every patient of asthma, be it mild intermittent, mild persistent, moderate or severe, must be put on an inhaled corticosteroid, either with a short-acting beta agonist or even a long-acting beta agonist. Overuse of salbutamol increases asthma deaths and should therefore be strictly used only as and when required basis. Please do not treat your asthma patients with regular bronchodilator drugs, especially with beta-2 agonists. Physicians must improve their communication skills to counsel these patients about the myths and the misbeliefs that are associated with inhalers and that are associated with steroids. You know, many asthma patients in India still continue to believe that steroids should never be used. Inhalers are addictive. They should be used only when the disease is very, very severe. So all those myths and the misbeliefs must be removed from your asthma patients through good communication skills. Physicians must teach and check inhaler technique at every visit, and patients must be encouraged to adhere to the treatment on a regular basis. I believe that if you follow these simple fundamental principles of asthma management, we will come out of this very bad shape that we are currently in. 43% of global asthma deaths is a very shameful figure for our country. And all the delegates, as I said, who are attending this meeting today, must take a pledge that none of their asthma patients will be denied an inhaled corticosteroid, because that is the only drug that will save lives. Reduce the underuse of inhaled corticosteroids and reduce the overuse of short-acting beta agonists is a very simple message that I would like to convey through this talk. So thank you very much, Club Dendigul, for inviting me for this wonderful seventh conference to deliver this oration. And I hope that I have communicated important pieces of information for all the attending delegates. Thank you very much.
Excellent talk, sir. Excellent. Right from the prehistoric times started, and it clearly showed how with the recent developments, the last 2020 guidelines was very useful, sir. How things have changed a lot. And good news for you, probably you will enjoy this. Since our club was initiated in 2014, all CIPLA lupin people have reported increase in their sales of inhaled corticosteroids and common budosine formula, whatever it is, in the past 5 to 10 years. Thanks to they instituted our Pulmonale, sir. We constantly keep on giving this message to all of persons. Your talk is well taken up, sir. One of the best talks about asthma. Thank you so much for being with us.
Thank you.
Excellent talk.
Thank you very much. Thank you so much. I can see Dr. Rajadhar is over here. Hello, Raja.
Welcome, Raja, sir. Welcome.
Sir, really hi, Dr. Sekar. Hi, Sandheep. Good to hear you as always.
Sandheep sir, really yes. A beautiful presentations. I am a practicing dermatologist, but I am holding the post of finance secretary in Club Pulmonale. As you rightly told, Sekar told, we have been emphasizing the importance of the inhaled corticosteroids, and you have shown the figures, really amazing.
Amazing. And
also you have insisted that the importance of the inhaled corticosteroids, underuse of the ICS in India. So due to your talk, because people across India, more than 500 delegates connected, they are all benefited, and it is eye-opener talk, sir. Really, hats up to you, sir. Hats up to you. So really, we will assure you, sir, we will definitely take up your point, and we will initiate, sir. Yes. The pledge will be taken, sir. And one more thing, sir, you have shown on slide the importance of the obesity. Really, it is amazing. Around 60 to 300% of incidence of asthma. Really, it is a new message for us today's talk. I want to know one important point: obesity due to high calorie food, or obesity due to environmental factors, which will the reduction in the weight will improve the reduction in the asthma incidence, sir?
Well, I think
you told that one of the most important cause of obesity is air pollution. It really struck us. First time we are hearing about it, sir. We are just amazed. How come, sir? How due to pollutants? How they influence weight gain and other things, sir?
So I was invited to write a book chapter on obesity and air pollution 5 years ago, and that is the time when I said, what is the correlation between obesity and air pollution? And at that point of time, when I did a review of literature, there were such amazing papers that showed very convincingly that air pollution causes obesity. And the reason of how that happens, many of these air pollutants contain chemicals that can disrupt the endocrine system. These are called as obesogens. So these pollutants are called as obesogens. When you inhale them through the respiratory tract, they enter inside the blood circulation and they affect the endocrine system to mess up with your body's metabolism.
Okay.
And there is a lot of research now. I think this is perhaps the hottest area for research in the recent times about how air pollution causes obesity. All this while we think that obesity was because of eating fatty foods and the wrong foods.
Yeah.
Exercise.
Lack of exercise. Yeah, that's what. Now,
But
new insights, sir.
But now we know that the quality of air that we breathe is also responsible for causing obesity.
So thank God we are in Dindigul, away from all metros.
Excuse me, sir. Dr. Kumaran from Madurai again. I
Yes,
just
Dr. Kumaran.
make a small comment and a question to Professor Sandheep Salvi. Wonderful lecture on recent management of asthma pathogens. Wonderfully explained by you. And definitely, it's very important that the message should be what is called provided to all the physicians, treating physicians. My one question is, when do you use oral or IV steroids and also the immunomodulator drugs in patients with asthma? Of late, there are a few papers regarding this, sir.
Okay, so systemic corticosteroids should be used in an acute exacerbation setting. So an asthma patient who has come to the hospital with an acute exacerbation, or an asthma patient who has come to your clinic, or even an asthma patient at home who has got an acute exacerbation, must be given systemic corticosteroids. Now, ideally, they should be given oral corticosteroids. They do not necessarily need to be put on intravenous. Patient is vomiting, is not able to hold the food inside the stomach, or is so breathless that you need to give systemic corticosteroids. That's the only time when you would give maybe intravenous corticosteroids. But systemic corticosteroids are to be given in a dose of at least 1 milligram per kilogram body weight to start with. So this can be around 40 to 50 milligrams of prednisolone to start with. And you need to give it at least for a few days. Check how the patient is doing. And then depending on that, you can taper it off slowly or you can stop it all of a sudden. The other drugs, such as the other immunomodulator drugs, such as methotrexate, can be used in patients who are not responding to high doses of oral or systemic corticosteroids. These are very rare cases that you would see, but we do see them. So methotrexate could be used. And then there are a lot of other biological